Hello, my dear colleagues in Philippines. It's an honor for me to be a speaker in this virtual conference. I would like to thank the organizing committee and Dr. Bernard Laya for inviting me to this meeting. I'm a pediatric radiologist at McMaster Children's Hospital, located in the McMaster University campus. Here you're seeing the Children's Hospital that I'm working with 10 more wonderful pediatric radiologists. My city is called Hamilton, and it's located 1 hour away from Toronto and 1 hour away from Niagara Falls and Toronto. And as you can see in the map, we are pretty much located in the north of the United States. The topic is spinal dysraphism, and it's not possible to cover within 30 minutes. And so I added a long video in my personal YouTube channel, and you can watch the full-length lecture from YouTube. But today I'm going to focus on some important points. I would like to start with the terminology first. Congenital anomalies of the spinal cord can be termed as spinal dysraphism, spina bifida, or neural tube defect. I like the term spinal dysraphism, and I'm going to use it. It means bad sewing in Latin, bad sewing of the back, basically. Spina bifida means, bifid means split, so it is split spine. There are many skin lesions associated with spinal dysraphism, and the risk increases with some of the lesions, as you can see here, and the risk is low in some of the lesions. For example, telangiectasia, simple dimple, hyperpigmentation, capillary malformation, or congenital hemangioma have low risk. Atypical dimple, hypertrichosis, infantile hemangioma, Y-shaped gluteal cleft, a tail or a skin tag is of high risk. So there is an increased possibility that these lesions are associated with spinal dysraphism. There are many different classification systems for spinal dysraphism. This is very simple and easy to understand. Basically, spinal dysraphisms are categorized into two as open and closed. Open ones are not covered with skin, and the neural elements are exposed to air. The closed ones are covered with skin and may be associated with a subcutaneous mass, or they may be without a subcutaneous mass. They may be completely normal, as in this case, or there may be a cutaneous marker, which is 50% of the cases. So this category was termed as spina bifida occulta for a long while, and this group is called spina bifida aperta because you can see them with your eyes, and these ones are occult. The terminology of spinal dysraphism can be quite confusing, so I wanted to illustrate here the main anomalies. There may be a posterior bony fusion defect, as you can see here. In meningocele, there is herniation of the thecal sac through this bone defect, and it's covered with skin, and there are no neural elements extending into the thecal sac. In myelocystocele, there is herniation of the neural elements into the thecal sac, along with the CSF spaces, both within the subarachnoid space and central spinal canal. And in limited dorsal myeloschisis, there is an covering skin and a skin lesion, and this skin lesion is attached to the spinal cord with a fibroneural stalk, and there is typical dorsal tenting of the spinal cord. In myelomeningocele, there is no covering skin. There is herniation of the neural elements along with the CSF spaces. In myelocele, there is only outward herniation of the neural elements, and CSF spaces are not associated, and the lesion is flush with the skin surface, and there is no covering skin. Myeloschisis is generally accepted as the severe form of myelocele, and the neural elements are protuberant from the skin surface. So what are these anomalies? You can see the open and closed spinal dysraphisms. In the open group, the most common one is myelomeningocele. The others are so rare. They're all rare, but some of them are extremely rare, as you can see in this group. And meningocele, for example, is a rare anomaly, very rare anomaly. And in the closed spinal dysraphism without a subcutaneous mass, they may have a simple dystrophic state or a complex dystrophic state, as you can see here. In this lecture, I'm going to focus on these anomalies only. I'm starting with myelomeningocele, which is the most common anomaly in the open group, comprising of 99%. Here you see a 1-day-old baby presenting with an open spinal dysraphism. The neural placode is exposed to air. Placode means non-neurulated embryonic neural tissue. Neurulation is the embryonic development of the spinal cord. So this is just a dysplastic neural tissue. And it's not covered with skin. There may be a very thin, fragile epithelial membrane. And here you can see how fragile it is. There is rupture of this part. And in this child, as soon as we removed the bandage, we were able to see the CSF leaking out, which means that there is a direct communication with CNS and the environment, and it's lethal. These children will die of sepsis and infection if they are not treated urgently. So after birth, they require urgent surgery just to cover this part. The surgery is basically to remove the placode and cover the skin, or just push the placode back into the spinal canal. This is a very common and important health problem because there is no function below the level of this placode. So they almost always have motor deficits, mild or severe. They are in the wheelchair all their lives, and there is associated Chiari-2 malformation, and many of these children will need a shunt all their lives. And because of the bladder dysfunction and anal sphincter dysfunction, they require catheterization of the bladder. They have kidney issues, infections, and reflux. So it's a very important problem. They usually get the diagnosis prenatally with an ultrasound. Here you can see the posterior bony defect on the ultrasound, and there is associated Chiari-2 malformation with dilated ventricles. And on the MRI after birth, we can see the herniation of the thecal sac along with the neural placode and associated Chiari-2 malformation with herniation of the cerebellar vermis and tonsils, a small posterior fossa, low-lying torcula, compressed fourth ventricle, and this is very typical presentation. Fortunately, there is now a prenatal surgery option for myelomeningocele. It revolutionized the treatment, and this is the first non-lethal anomaly to be treated in utero. To give you an example, here there is a fetus, 9-week-old, and there is myelomeningocele, but we are not seeing it. It is there, I know, because the neurulation, the development of the spinal cord is completed at the age of 7 weeks, and this patient is 9 weeks, so there is myelomeningocele here, but our resolution is not good enough. And at the age of 20th week, we are able to see it on the ultrasound. Here you can see the bony defect. There is no covering skin or bone, and there is associated lemon head, atypical for Chiari-2 malformation. So we confirmed our findings with a prenatal MRI. In this case, here you can see the Chiari-2 malformation, herniation of the cerebellum in through the foramen magnum, and there's bony defect, and there is no covering skin or membrane, and it's Chiari-2 malformation again, the ventricular dilatation, colpocephaly, and on the coronal we can see it. So this patient had this in utero surgery at the age of 25th weeks, and we did a follow-up MRI after the surgery. Here you can see the closure of the defect. There is no communication now, and we can see the improvement of the findings of Chiari-2 malformation. There is still some herniation of the cerebellum, but it is significantly improved. There is a larger posterior fossa now, So the findings are better, and we were able to see some gray matter heterotopias in this case. So the surgery can be done endoscopically or open or a combined approach, and they have the similar results. And it is very helpful, and it has become the standard care now because it significantly improves the motor deficits. It significantly improves the need for shunt. The results for bladder dysfunction or anal sphincter dysfunction is mixed, and there is no improvement for the tethered cord symptoms, but has been a standard care for years. After the myelomeningocele, I will skip to another important topic, myelocystocele, and I'm going to discuss it along with limited dorsal myeloschisis, the saccular form and non-saccular form. Terminal myelocystocele, or the distal or the sacrococcygeal myelocystocele, is a severe spinal dysraphism. It is characterized with a covering skin, herniation of the neural elements, along with a meningocele and hydromyelia. And on the MRI, it may be associated with a Chiari-2 malformation, and the diagnosis is based on seeing the herniation of the central spinal canal, which is dilated, and on the coronal images we can see the staying of the spinal cord, and we can see the cyst appearance formed by a meningocele and hydromyelia. These anomalies are clinically very severe, and they may be associated with complex anomalies, anal atresia, omphalocele, or cloacal malformations. And the prognosis is poor. They usually have bladder dysfunction. In addition to the terminal myelocystocele, there is non-terminal myelocystocele, which is a completely different anomaly. It's more benign, and it has better prognosis compared to terminal myelocystocele. You can see two examples that I borrowed from my friends. In the non-terminal one, they are rarely associated with Chiari-2 malformation, and there is a covering skin. The patients can be completely normal neurologically. So they are two different anomalies. In limited dorsal myeloschisis, the diagnosis is based on a cutaneous lesion and a fibroneural stalk, which is anchoring the spinal cord to the skin lesion. There may be hydromyelia in the stalk or not, and this is the source of the non-saccular and saccular terminology. And on the sagittal image, we can see the typical post-tenting of the spinal cord. So as you remember with the term myelocystocele, the non-terminal myelocystocele is exactly the same as the saccular form of limited dorsal myeloschisis. So there's an overlap in the taxonomy. In the classification, there's an overlap. In limited dorsal myeloschisis, it can be non-saccular or saccular. Two examples. Here is the lesion covered with skin, fibroneural stalk anchoring the skin lesion and the spinal cord. There is tenting of the spinal cord, and we can see the same findings on the axial images. In the saccular form, there is the hydromyelia and meningocele, and it's always attaching to the cutaneous lesion. The understanding of limited dorsal myeloschisis have been clear in the recent years, and in this group of surgeons actually published an excellent review paper, and they even described the subgroups of the saccular form. They have typical cutaneous lesions, and the crater or the cigarette burn mark is very diagnostic for non-saccular type of limited dorsal myeloschisis. The understanding of limited dorsal myeloschisis is important because on the classification there's an overlap with the non-terminal myelocystocele. In the prenatal ultrasounds, they usually have the wrong diagnosis of myelomeningocele, and which is very dangerous because these group of children have much better prognosis. They can be completely normal. They may not have associated KRE2 malformation. And embryologically, they are in the same category of dorsal dermal sinus tract, and they may have a tract as well, which is not a true sinus, but they have the tract, and they may be associated with other anomalies, such as dorsal lipoma, such as thickening of the phylum, such as tethered cord. So we should be careful and we should be cognizant of limited dorsal malleolus cases. Just to give an example, this is a newborn with normal physiological examination and protuberant skin lesion with no opening of dimple, but on the MRI that we performed around 3 months of age, we see this lesion, and it was reported as myelomeningocele, but this cannot be a myelomeningocele because it's covered with skin. A myelomeningocele will not survive until 3 months of age. And here we can see the dorsal tenting of the spinal cord, which is very typical. The location is just above the conus. Conus is slightly low-lying, and we can see the fibroneural stalk anchoring the skin lesion. And we can see the sinus tract, remnants of sinus tract. It's not a real tract, but it's there. So this should not be reported as myelomeningocele, and there is no associated KRE2 malformation. They may be associated with other anomalies, as in this case, there is associated neuroenteric cyst. Here is the lesion with a thick squamous top, and we can see the stalk, and here is the fibroneural stalk. So this is associated with other lesions. And here you can see the tenting of the cords. And embryologically, it's in the same group of dorsal dermal sinus tract. And here is, on the one hand, limited dorsal malleolus cases, on the other hand, dorsal sinus tract. Here, in this group, for example, this one is associated with dorsal lipoma, and there is this tract, but it's not a real tract. And this is a real tract and infected. So what are the differences? How do we differentiate them from dorsal dermal sinus? And these are typically presented with cigarette burn mark, non-saccular forms especially. And dorsal dermal sinus tract is presenting with a dimple or a pinpoint ostium. In this group, there is a solid tract without a lumen, which means that these children do not need an urgent surgery during the neonatal period, and they are rarely associated with dermoid cysts. But in this group of dorsal dermal sinus tract, because there is a communication that may cause a central nervous system infection, they require urgent surgery, and they are commonly associated with dermoid cysts. Intrathecal tracts are entirely or partially visible in limited dorsal malleolus cases, intrathecal portions. And in the dorsal dermal sinus tract, we can see the extrathecal part better, but intrathecal parts are barely visualized. And in limited dorsal malleolus cases, tracts are associated to the spinal cord above the conus with characteristic dorsal tenting, and tracts terminates in various structures, including the dermoid cysts. These are some common differences. Next topic in my talk will be lipid-containing anomalies, as you can see here, and I'm going to start with lipomyelomeningocele. It's a closed anomaly associated with a subcutaneous mass. Unlike myelomeningocele, the terminology is based on the placoid-fat interface, not the CSF spaces. So if the placoid-fat interface is out of the spinal canal, it's called lipomyelomeningocele, not lipomyelocele. There is always a low-lying cord attached to the fat, and there is always a bone defect and increased subcutaneous fat. And in this case, there is associated syrinx cavity. As you can see here, there is no KRE2 malformation, and lipomyelomeningocele, unlike myelomeningocele is not associated with Chiari-2 malformation. The anomaly is just Chiari-1 malformation, which is completely different. The posterior fossa is normal. It's just the herniation of the cerebellar tonsils through the foramen magnum. However, in lipomyelocele, the plaque-fat interface is within the spinal canal. The lumbosacral lipomas have been investigated significantly in the recent years, and we can describe them as dorsal lipomas if the fat is attached to the spinal cord from the dorsal aspect. It is called caudal lipomas if it is attached to the spinal cord from the caudal aspect. These are all different patients. And there is a combined form, which is dorsal and caudal combined. It's also called transitional form. And the intradural lipoma is attached to the cord from the dorsal aspect and the caudal aspect at the same time. And we have the lipomyelocele and lipomyelomeningocele group and the filar lipomas in this group. So we can describe them as it is. There are many different classification systems. I summarized here some of them. And there is even a classification system based on embryology. So in this group seems to have a worse prognosis than the other, even with surgery, transitional or chaotic form in the according to Peng. And the final group, type 4 or the filar group, has the best prognosis. The next topic will be tight film terminale, which is a closed spinal dysraphism without associated subcutaneous mass, also known as tethered cord. Determining the level of the conus is the hallmark of diagnosis for tethered cord because a low-lying cord is seen most of the time in tethered cord. Early in fetal life, the level of the vertebra and the spinal cord is equal. Because the bone grows faster than the spinal cord, a discrepancy occurs later in gestational life. In the preterm infant, the level of conus can be as low as mid L3. In the term infant, it's usually around L1, L2, and in the adult life, the level of the conus is L1 or above this level. Here you see the nerve roots and the filum terminale, which is in red color. As you can see, if the cord is low-lying in the later ages, the nerve roots will be shorter, and this won't change with surgery or other treatment. Patients with filum terminale can be completely asymptomatic, or they may present with neurological symptoms or signs. I will give you 3 examples for surgical treatment. In this child, 6-month-old with dimple, had the MRI and tethered cord or tight film terminale is confirmed. There is a low-lying cord and it is attached to a small lipoma, and there are no neurological abnormalities in this patient. But this patient had a syrinx cavity, and therefore the surgeons decided to do the surgery, and after the surgery there was resolution of the syrinx cavity. And as you can see here, the level of the conus has not changed after surgery. The treatment is to identify and cut the filum. That's the only treatment. If there is an associated lipoma or other lesion, they also resect that lesion. In this case, they resected the lipoma, but there is still some residual lipoma, and there are no symptoms. So the indication for surgery was the associated syrinx cavity. Another child born with a dimple, and we are doing the MRI, and we are showing the tight filum terminale. There's a low-lying cord. The level is L3 to L4 here. And on the second day of life, 5 weeks, we are doing a follow-up MRI on the second year of life, and there's a syrinx, very little syrinx cavity within the distal spinal cord. Although there were no symptoms, the surgeons decided to do the surgery because of the presence of a syrinx. And after the surgery, there was resolution of the syrinx cavity, and they cut the phylum. And the child is doing very well, playing hockey. There is no neurological deficit. And as you can see here, after the surgery, the level of the conus has not changed, and it's not expected. There is no elastic recoiling after the surgery. Another example, 8-year-old asymptomatic patient with hair tuft. That's why we did the MRI. On the MRI, we saw the low-lying conus associated with a small lipoma. It's attached to a small lipoma, and the surgeons decided to follow this up. And then when the child was 11 years old, there were some symptoms, some numbness on the top of both feet, pain in the right shin, so the surgeons decided to do the surgery. And after the surgery, as you can see, there is not much change. The level of the conus is same as expected, and there is still some residual lipoma, but the symptoms have resolved, and there was improvement of the frequency and rare back pain, but they were not completely healed. So this is a typical tethered cord presentation and surgery. The next anomaly I'm going to talk about is split cord malformation. This is a closed spinal dysraphism without associated subcutaneous mass. There is usually an associated cutaneous marker, which is hypertrichosis. Basically, there is splitting of the spinal cord, and there are two types. Type 1 is more severe. Type 2 is basically the milder form of type 1. The main difference is presence of a cartilaginous or bony septum in type 1, and in type 2 there is no bony or cartilaginous septum. There may be no septum, or there may be a very thin fibrous septum. There is usually an associated low-lying conus, and at surgery it is vital to resect the cartilaginous or bone septum. That's why many of the surgeons order a CT study in addition to an MRI study to confirm. So these were the anomalies that I wanted to focus on. Before I finish, I would like to discuss for 2 minutes an anomaly which is not considered as spinal dysraphism, but it has become very popular. So this is, in order to understand this, we need to know the normal coccyx anatomy. Normal coccyx has usually 5 vertebrae, and they are usually rudimentary. At birth, the first one is usually ossified, and the ossification is somewhat different than the sacrum. It is more round compared to sacrum. And this is the normal physiologic kyphosis of the coccyx, and this is the expected anatomy. But there are some variations in the anatomy of the coccyx. Some variations, this is more like an expected, more fully formed coccyx, and in this one there is anterior angulation of the distal coccyx. That's the posterior aspect, skin surface, and sometimes we see it an abrupt distal end. Because this part is cartilaginous, it appears very hypoechoic. And sometimes there is a posterior angulation of the distal coccyx. It may be very short. Sometimes there is a beak, anterior beak, as you see here. Sometimes there is a dorsal angulation and dorsal beak. These are some variations, but some of them are more severe, and we can call them as dysmorphic coccyx because they don't show the physiologic kyphosis, but rather they extend to the skin surface posteriorly. They show an angulation posteriorly, they extend to skin, and where they meet the skin surface, they usually cause a dimple. Here you can see the dimple, a dimple, and they are extending to the skin. The cartilage is very hard. And here is an example. That's the dimple, and there is posterior angulation of the distal coccyx, and this is a dysmorphic coccyx, and at palpation, it may be palpated as a hard lump. And this is how it appears on MRI. You can see the coccyx angulated posteriorly, but there is no associated other anomaly. And this is just a simple dimple. It's very small, close to the anus. There is no associated cutaneous markers, and it's in the midline. And this dysmorphic coccyx can be associated with a sinus tract, but it's usually not a real sinus tract. There is no opening, and it doesn't extend to the thecal sac, which is at the level of S2. So it is just a short tract extending between the dimple and the tip of the coccyx, and this doesn't have any clinical significance. It's not considered as a spinal dysraphism, and we should be cognizant of that. Thank you very much for listening.